All right, so thanks for coming, everyone. So what we're going to do today is work through COVID intubation and go through some of the main differences around intubating one of these patients. So the main thing really about this is you want to be able to protect yourself and your team members from the aerosolation of the particles that can happen. In terms of risk to you, this is probably the highest risk procedure that we're going to do on a COVID patient is the intubation. And the risk of generating the aerosolized particles of the COVID virus during the intubation is really high. If you look at the SARS outbreak, these were the people that got really sick, the doctors that got really sick or ended up in ICU, or the ones that were intubating patients. So I don't want to put fear into you, but this is the time that you want to put on your PPE properly and look out for each other, make sure there's no breaches to that. So what we're going to go through today is putting on our PPE and having a buddy system, so everyone's checking that the PPE is put on appropriately. In terms of PPE, there's a little bit of difference to what we're normally doing. So we're using an impervious gown, which is either the gastro gowns or the trauma gowns. We're using a face visor or a mask, and N95 mask definitely. A hairnet, and we're double gloving, and ideally the top layer of gloves should be a pair of surgical gloves, just because they go down past the sleeves of the arm and less likely to go up. The highest risk moment of the intubation is going to be when you're bagging the patient, or when you're putting the bag valve mask on the patient, or going anywhere sort of within 2 meters of the airway. So what we're going to do is ideally set up the room outside. So we're setting up all our equipment outside the room in either an ante-room or just outside of a room with a closed door. And ideally this should happen in resus 3, but we may be overwhelmed, and so we may have to adapt to that. And so the next sort of cubicles will be ones with doors that we can shut. Any questions so far? There's a lot of people in the room. So
if you didn't have the mask with the visor,
yeah,
is it safe enough to use a normal N95 mask with goggles?
I personally wouldn't, yeah. We can get those from theatre, we can get them from ICU, and we're looking into getting the visors actually come down over your face as well.
Would you still need to have an N95 mask?
N95 mask always. So I would always put an N95 mask and a surgical mask with a visor, just because I feel like the filtration is probably better with the N95 than the surgical mask, as long as you've got a proper fit. In terms of the intubation side of things, we're setting up all our equipment outside the room. When we come into the room, the people that you want in the room are the people that are necessary to perform the intubation. Everyone else can wait outside. So we want the airway doctor, the team leader who is also airway competent. And when we say airway competent, we're talking more than 100 intubations sort of experience. And we want an airway nurse to come into the room as well. Now that airway nurse may already be in the room caring for the patient. And so when you come into the room after you've been outside, set up your equipment and everything, it's important to let the airway nurse know what the plan is going to be. So your plan A, B, C, and D. You don't need to go through the whole checklist again. That airway nurse shouldn't be someone learning how to do an airway for the first time, is sort of what we've said. We've got a couple of educators in here as well, so they're all on board with that. In terms of, and we'll walk through the process, but the main point of aerosolization is going to be when you remove your high flow nasal oxygen. So you need to turn this off at the machine before you disconnect it from the patient's nose. And then we want you to bag with a two-handed bag technique and a filter on your bag valve mask. Don't squeeze the bag, and we're not doing apneic oxygenation of any sort, so no nasal prongs and no apneic bagging. And really it's about defending sort of hypoxia to a point where the patient becomes unstable, I guess. So for me it would be low 80s, looking like they're starting to become bradycardic. Then I would think about potentially doing a couple of breaths, but the idea would be to try and get the tube in before you start ventilating the patient.
Because that valve doesn't open, there won't be the flow.
Exactly, yeah.
Yeah. Cool.
So yeah, in the bag valve mask you mean, yeah, so there's no flow if they're not in training air. Like, the next critical moment is after you've intubated the patient, the cuff needs to be up, the bougie can come out just slowly, not flicking around in the air, which is one thing we've noticed, and a filter attached to the inline suction attached to the top, and then a filter is attached to that. And then it can either be connected to a bag valve mask with end tidal or directly to the ventilator. It's up to you. If you are going to change from a bag valve mask and ETT, then you need to clamp the tube to stop an open circuit. The other main thing is high dose paralytics are really important, and wait the full 1 minute for the paralysis before you attempt intubation. You don't want the patient coughing or spluttering in that period where you're sort of right at the airway. Video laryngoscope is probably the preferred option, and we're getting hopefully some disposable blades as well, so we should have enough to go around if we run out, if the other ones are off at CSSD or being cleaned, and a bougie as well. So what I might do is just go through the whole process and run it like a sim, but ask plenty of questions as we go. If you're not sure about something, ask, and we'll clarify that, and then we'll just have a quick debrief at the end.